Dr. Nadia Khoury is a board-certified endocrinologist at Downriver Endocrinology, PLC, where she has practiced with her father since 2012. She takes care of adults of all ages and endocrine disease, including type 1 and type 2 diabetes, mellitus, thyroid disease, adrenal disorders, and pituitary disorders. Dr. Khoury graduated with her MD from Case Western Reserve University in Cleveland, Ohio. She completed her postgraduate training in internal medicine and endocrinology at Washington University School of Medicine, Barnes-Jewish Hospital in St. Louis, Missouri. She is a member of the American College of Physicians, Endocrine Society, and the American Association of Clinical Endocrinologists. With that, we welcome Dr. Khoury.
Good morning, everyone. Thank you for having me. This was a learning experience for me as well, to dig deep into the data as well. So I appreciated the opportunity to do this as well. I'm happy to see some of my patients here and some of my colleagues and people from all over. So today we're going to talk about the basics of acromegaly, incidence and prevalence, clinical presentation and its variety, what comorbidities are seen at diagnosis, biochemical and imaging diagnosis as well. So some of this may be more basic than you guys already know all this, but I'll review it. So the most common cause of acromegaly is a growth in the pituitary gland. So this is 95% of cases. Rarely we can get acromegaly from genetic disorders or due to a tumor that is elsewhere in the body, usually a cancer that's secreting growth hormone. And the way to understand our system and to understand all of endocrinology is negative feedback loops. So think about your thermostat and your furnace is the best analogy to use. So here the thermostat is the pituitary gland and the liver is the furnace. So the pituitary gland secretes growth hormone in a pulsatile manner, mainly during sleep and exercise. It tells the liver to secrete IGF-1, some from the muscle, some from the bone as well. IGF-1 circulates around your body, does what it's supposed to do, what growth hormone's supposed to do. And when the pituitary gland senses, hey, there's enough of this around, it turns down growth hormone secretion, which regulates what the liver does. And so it's a thermostat and furnace. So in acromegaly, the pituitary gland starts to secrete too much growth hormone, escapes the negative feedback loop, and suddenly you have too much growth hormone, too much IGF-1, and you get in trouble. In 70% of these cases at diagnosis, the tumor in the pituitary gland is already over 1 centimeter, so we consider it a macroadenoma. 1 centimeter is about a half an inch. So us doctors are always told acromegaly is so rare and so we're looking for a zebra out on the safari kind of thing. But actually it's probably more common than we think. So the way we're looking at these slides, oops, sorry, I forgot to advance. Oh, sorry about that, guys. We'll do some descriptive nature of our slide. So this slide that's missing is about incidence and prevalence of acromegaly. So we're initially taught that acromegaly is a rare disease, but we actually think it's more common than we first thought. The first half of the slide showed various registry studies, so where they followed populations and basically found all acromegaly patients in countries all over Europe, South Korea, in North America as well, Mexico and Canada, and some US studies. There aren't a lot of US studies about this. And the prevalence ranged anywhere from teens to maybe 40 to 60 people per million people, with the mean age in the 40s. And now I don't know what it is. And these data ranged all the way from the 1990s all the way up until the 2010s. I don't know why I would do that. And then in a second study that sort of went through this data more from the Danish population, because if you guys don't know, Europeans love counting things, especially the Scandinavians. And there, the incidence of acromegaly was pretty flat over a 20-year period that was studied. And incidence means how many new cases you have in a given year, while the prevalence went up, and prevalence means how many cases new and existing exist, which means people live with the disease for long periods of time. Okay, now we're back. And the one United States data that is available, it was based off of pharmacy and healthcare utilization databases, and it showed that in the US, our incidence is about 3,000 new cases per year, or about 25,000 total cases per year prevalence. There's a large US registry database going on right now. Women and men look to be about equally affected, because that's the best chance we have to minimize all the other things that can happen and to get to a cure. So on the left is a study where they looked at, my slides aren't showing up, so how comorbidities, so bad things that happen associated with acromegaly, and the earlier the diagnosis, the less the comorbidities. So in black over here is when diagnosis was delayed more than 10 years, and the number of comorbidities goes up. So this is no delay in diagnosis, this is less than 5 years, this is 5 to 10 years, and greater than 10 years. And this was, so as it went up, people had more problems happen. Down here is standardized mortality rates. So the longer it takes to get diagnosed, the higher the mortality rate. And so the other point of this is for our neurosurgery colleagues, surgery is a lot easier when it's tiny versus when it's big and is going places. And so that's why early diagnosis matters as well. Maybe it will come up. So what I think most importantly of is if you, to diagnose acromegaly, you have to think about it first. Not all patients with acromegaly will look the same. I've picked someone up in the hospital when I told them, hey, your nose looks funny, come see us in the office. And I wrote Dr. Asmaro's name on the back of a card and I said, this is probably what it is. I don't know what your IGF-1 level is, but it's probably accurate. While other patients can come with varieties of presentations, women diagnosed with PCOS, men who have just sleep apnea. On the right here is the original studies from Pierre Marie in the late 1800s, and these are patients' photographs from the original studies that were published in France when this was described. And then this is something from the Acromegaly Association showing patients at variety of stages of their disease. So symptoms and signs of acromegaly, most of us may have personal experience of this and see lots of patients with this. So most importantly, you have skeletal or acral changes, so growth of your jaw, swollen hands and feet. Maybe my slide will come up. Okay, we'll use this one, that's all right. You can develop arthritis, coarsened facial features, you sweat a lot, you can get carpal tunnel syndrome, obstructive sleep apnea, your thyroid gets bigger, most of your organs get bigger, you have a higher incidence of colon polyps, high blood pressure, the walls of your heart get bigger. If it goes on long enough, you can develop weakening of your heart muscles, you develop insulin resistance, and you may be at risk of developing diabetes as well. And you can have high phosphorus levels, which may be a clue if you're looking for it. The most common complaint in large-scale studies that people had at diagnosis was changes in their hands and their feet, so acral changes, and headache. And Dr. Cusimano at the beginning said that they've started to look at ways for AI to do this. And there was an early study that said machine learning methodology could diagnose acromegaly based off of analysis of facial photographs with a positive predictive value of 96%, which is fantastic for research studies. This is the next slide I had up. So us medical people learn in mnemonics, which I did not know either of these two mnemonics, but now I do. So big hand, bone growth, increased sweating, growth hormone excess, hypertension, arthralgia, nerve compression, carpal tunnel, and diabetes. And then A, B, C, D, E, F, which I'm not going to remember that one, which includes some of these additional things as well as visual field defects. And over here, symptoms of acromegaly, which we've reviewed some of already. So this is, I think, one of the most important slides here, which is us doctors may think of acromegaly as one thing, tumor and what to do with it, growth hormone, what to do with it, and comorbidities and what to do with them. But there's also all this stuff under the iceberg, or you could use the swan going crazy underneath the water analogy, whichever one works for you. And this is a direct quote from one of these studies that says, invisible, less well-managed handicaps at the root of persistent socioeconomic burden of acromegaly, even in controlled patients. So what this tells us is we may know what we think we know about acromegaly, but there's a whole lot more that's happening underneath the surface that needs to be addressed as we look at a whole person while we're treating them in clinic. And it also tells us that we need to have multiple services involved. It isn't just an endocrinologist and a neurosurgeon and an ophthalmologist having a discussion and deciding you get this and you get this, but it's probably have a psychologist involved, have a social worker, a case manager involved, so that we can get services to people when they need them. So in what we look at is what is quality of life like? And this is one of the areas where acromegaly actually excels, where there are quality of life indicators and quality of life studies available and standardized forms that can be used to assess this. I didn't actually know these existed, and so now I do, and I can apply them in my own practice. So this is a recent Romanian study, because I wanted to bring something recent that was just published a few months ago, where they assessed 40 patients over 7 years. And what they found was, let me see, where is my pointer? Sorry. So we'll start from the bottom. So women and men had lower global scores than men did in all subdimensions. And the subdimensions are physical score, how you look, psychological score, how you feel, appearance as well, and personal relationships leading to a total score. But other things that we thought that you would think would impact on how you feel about your acromegaly, including your size, your BMI, your educational status, where you live, had no impact. Patients who were employed had better scores all over than patients who were unemployed. Disease activity didn't correlate with worse quality of life, but patients who achieved disease control, they did better, just not statistically significantly better. Okay, showed up. Okay, so what we talk about are what shows up when diagnosis, and what you're having from your acromegaly at the time it's diagnosed impacts how quickly you get diagnosed. So if you have things like headache, visual field deficit, come in with a seizure, and its local effects, you're more likely to get diagnosed quicker. If you have endocrine problems, your testosterone's low, you're having irregular periods, you're not unable to conceive, or you're having co-secretion from the tumor, like prolactin leading to galactorrhea or milk discharge when it shouldn't be there. That's the second most quickest to get diagnosed. Cardiovascular stuff like heart hypertension that's uncontrolled, respiratory things, most commonly we think about obstructive sleep apnea, musculoskeletal complaints like all the skin and bone changes we're having, neoplasms, whether they be a plethora of colon polyps or other growths that people are having. But the thing that leads to the greatest diagnosis is neuropsychiatric complaints. So changes in mood, changes in behavior, that is the thing that leads to the biggest delay. And so what this tells us is we need to think about the disease, right? It always has to be in your back of your brain differential. Now, there's no screening recommended with an IGF-1 for isolated sleep apnea. So if you walk into the doctor with sleep apnea, they don't recommend that you just grab an IGF-1 on everyone. If you have uncontrolled diabetes, we'll get to why in a second that you shouldn't check an IGF-1 until if you're still suspicious later on, you can once they're controlled. Or isolated carpal tunnel, because let's face it, we're all on the computers for way too much time in our day, and everyone's getting carpal tunnel. But if conditions cluster together, if you have hypertension, sleep apnea, uncontrolled diabetes, you have PCOS and other things going on that make you think of this, then it's reasonable to be checking an IGF-1. So now we've talked about we're suspicious for acromegaly. How do we diagnose it? So IGF-1 is our best assay to test. So the reason we don't measure growth hormones, random growth hormone levels, is because, as I said, they're pulsatile, so they go up and they go down. They also are diurnal, so they vary at the time of day that you're measuring it, and they can be stimulated by short-term exercise, short-term fasting, exercise, stress, when is anyone not stressed, and sleep, and then growth hormone clears out of the system rapidly. So it's difficult to use. Levels fluctuate widely, and people with acromegaly can have normal growth hormone levels if you just measure them randomly. So we don't use growth hormone levels. So we use IGF-1s. So an IGF-1, the points here are, it can vary lab to lab, and this is the nature of the assay. And so if you have a high suspicion for acromegaly, go get retested at a different lab, hopefully with a different assay, using either a national reference lab or something where an institution where we know they know how to measure IGF-1. IGF-1 levels can be misleading. So in poorly controlled diabetes, people with chronic A1C is above 10%, you're not reliable. If you're a woman on birth control pill, the estrogen in there will throw it off. If you're severely hypothyroid, that will throw it off. If you're malnutrition, and then if you're just old, it doesn't matter as either. And so what do we call an elevated growth hormone level? So 1.3 times the upper limit of normal, which for a lot of testing we do in the endocrine world, that's not a big elevation, right? So when I'm looking for a pheochromocytoma, I need like 3 to 4 times the upper limit of normal. So in this, it doesn't take much to get off. The blood test is best done early in the morning fasting, so before 10 a.m. Once you have an elevated growth hormone, if you have an elevated IGF-1 level and you're like, yeah, this is acromegaly for sure, then you can move on to imaging. But if there's still clinical wavering, you can do a growth hormone suppression test. This is a little picture graph about this. So what you do is you give a person an oral glucose load. So I tell people it tastes like melted orange popsicles. That's the taste of it. It's what women get when they're having a glucose tolerance test during pregnancy. So you drink this, then you get your growth hormone levels measured at an hour and 2 hours and 30 minutes. And what's supposed to happen is that when you take in sugar, the growth hormone levels are supposed to go down, and if they don't, we need to do something about it. So the diagnosis, you need to get a picture of your brain, a pituitary MRI. If you've had acromegaly, you've probably had one. This is the little cage that you've had. I've had a brain MRI before. I actually fall asleep in MRI machines. I don't know how, but it's calming to me. I don't need anything. You may need pre-medication for claustrophobia if you're someone who can't handle that. It does require IV gadolinium. This is different than IV contrast, so if you have a shellfish or an IV dye allergy, you don't need all of that pre-medication crap. You just need to, it's different contrast. The only thing is if you have chronic kidney disease, you have to be careful of gadolinium still. And you want to go to a machine that's a 3 Tesla machine, because you can get smaller slices. So we're doing slices of bread here, imagine. So you don't want thick crust bread here. You want really thin crust bread. And so we're trying to get the thinnest slices possible. Yes, I know, I have corny analogies. I'm a dad joke. So our comorbid conditions that we screen for, now you can do all of this on their first, start making all these recommendations on a person's first visit, but you're going to overwhelm them if you hand them this big stack of referrals and say, do this and do this and do this and do this. So dribble it in. So get a fasting glucose and an A1C, DEXA scan looking for osteoporosis, refer for a colonoscopy. Don't do a Cologuard, refer them for a colonoscopy. A sleep study. These can be done in the comfort of your own home. You don't have to go sleep somewhere foreign from you. You should get an EKG, because if they're going to go to surgery, they should get one as well. Get their blood pressure monitored, eventually get an echocardiogram. And then these are things to be followed over time. And that's about it. We are in Southgate. I'm in practice with my father, and we are using the Epic MyChart EMR system, and we round daily at local hospitals. I'm available for questions after. That slide showed up. Should I maybe get my laptop and see? I have like 4 slides missing. Yeah, let me do that.